My name is Allison Weiss, and this is my Organizational Culture and Readiness project. I conducted my interview with one of my previous preceptors who works at a school-based mobile unit at one of the local schools near where I live. And we sat and talked a little bit about previous projects at her site, and we talked about my project regarding HPV. So first, I started by asking her what are some of the barriers that she has seen for people getting the HPV vaccine. She said one of them she believes is the provider information. So what she meant by that is, are the providers all sharing the same kind of information? Are they sharing different information? Are all of them vouching for vaccines? Are some of them a little more lenient and hesitant to discuss vaccines? And what kind of information are all of them providing? Next is a lack of understanding of HPV related cancers. She says a lot of the general population just doesn't understand that HPV is more than cervical cancer, and it can cause cancer in men and all kinds of different cancers in both genders. The last barrier she said she's noticed is kind of this political climate regarding vaccines and a lack of trust in the government and big pharma companies who are producing these vaccines. She said a lot of people experience hesitancy when it's talked about so much in the media and when it gets involved in politics. So she's noticed that that is getting brought up a lot more in her discussions with people about vaccines. I asked her what are some misconceptions you've heard from parents regarding the HPV vaccine. One of them is safety. That's kind of across the board. A lot of parents worry that it's not safe for their kid. Another is a misconception that by providing the HPV vaccine, it's going to increase sexual activity in the adolescents who receive it. Another one is that some of these children are young, and perhaps they're really young and are hopefully at an age in which they're not sexually active yet. For example, ages 9 to 12, that's a very young age, and these parents believe that they're young and not sexually active and should not need a HPV vaccine. The next misconception in the general public is that boys do not need the vaccine, but it's quite opposite. Males can also receive the HPV vaccine. And last, the thing that a lot of parents kind of get confused about is that the HPV vaccine is not going to provide an immediate result. It provides antibodies throughout 10, 12 years. It's not like the flu vaccine where if you get the flu, you hopefully can avoid it or not get as sick that season. And a lot of parents don't comprehend or don't quite understand that you can get the vaccine right now and it's going to provide immunity for a very long time. I asked her, does she see many parents refusing the HPV vaccine for their children? And she said it kind of varies. She said that some parents will come to their appointment and know that their child is of age and actually come and ask for it or ask where they can get it. Some, on the opposite hand, she will bring it up to them and say, hey, your child's at age, she could receive the vaccine. And that's when they start having those conversations about different misconceptions. I asked her what are the barriers as a provider to get children vaccinated for HPV. She said sometimes she struggles to have enough well child visits as the children get older. When children are really young and they need their MMR and other vaccines like that, and they're coming consistently every 4, 6, or 8 months, something like that, they are seen a lot more often versus when they get older and life gets busy and there's other children who have greater priorities, that the well child visits aren't always kept up as much. And that moves into the next topic she talked about, which is rural health. A lot of people in rural West Virginia have a tendency to only go to the doctor when they're sick and not talk about health prevention. And she said another thing is that these children are sometimes only making it to appointments when they are sick and not just for health prevention because it's such a far drive for them. If they're 30, 45 minutes away from their regular practitioner, are these parents making sure that they come in and get their health prevention measures? The next is that some children don't come back for the second vaccine. So we see a lot that children will get the first round of the HPV vaccine, but they don't always come back for the second, which is not necessarily for side effects, but again, just the convenient factor of how far away are they, when's the parent going to have time to bring them, and things like that. And the last, again, I mentioned earlier, is social media and the political climate regarding vaccines right now. And a lot of parents getting on social media and seeing, well, my neighbor down the street isn't giving her kid the vaccine because of this, this, and this. And providers are having to work really hard to push back against what's being said in the media and provide parents with evidence-based practice and proof that this vaccine is really beneficial. So, when discussing the organizational readiness with my preceptor, she does believe that her place of work is an environment of learning and being eager to learn. She thinks that they definitely try to stay up to date on the best evidence-based practice, and she reports that leaders and management are really willing to implement time and practice into promoting new evidence-based practice. She says that they have monthly meetings on the first Wednesday of every month, and in previous years, they've discussed what's going right, what's going wrong, what things that they want to change to stay up to date with the ever-changing healthcare environment. She reports that they've actually tried new evidence-based interventions in the past, and she does believe that her employer is open to quality improvement and change. She did mark agree for the organization providing mentors. She said she doesn't necessarily know that it's a mentor, but she knows that there are people she can work with if she wanted to try something new at her job. In my personal experience at this clinic site, there was an environment of being eager to learn, being eager to try new things, and especially being eager to talk about vaccines with families. So that's why I particularly loved this place. They are very inclusive of families and the children. When talking about steps to create a change and what she would do, she said that she has no difficulty with presenting a problem to her manager or anyone in leadership. And sometimes they even have meetings just amongst the care team. So whether that includes some of the psychiatrists, the psychologists, the community health workers, the medical assistants, or if they have a meeting with just the providers, the PAs and NPs, talking about something that they want to see being done differently or something that they want to try. They'll discuss the steps of that change and try the steps and then report back what are the barriers that they're finding. She says that one of the goals and one of the things that they were trying to get better at recently was increasing the amount of well child visits that they were having. She said it's just a really rural community and a lot of parents don't bring their children in for well child visits. She sees them a lot for acute care visits. And she feels that sometimes this is something that's missed, especially in a school-based setting. So what they tried to do is set a goal of how many well child visits that they'll see in a day, over a week, over a month, and that they're monitoring how many well child visits they get in. And they kind of promote the well child visit. If the child comes in for a acute visit, they fell on the playground, they have an ear infection, then my preceptor would take the opportunity to say, by the way, we do well child visits. If you want us to do a vision and hearing screening, a physical exam, get them up to date on their vaccines. They even have vaccines on the mobile unit to provide to the children so they don't have to go to a pharmacy and they can do it right there. And she said that after they started to kind of make sure that they were encouraging the well visits, that they started to go up. Based on my interview, it became clear that there is a need for parental education regarding the HPV vaccine, and that it's really important here in our rural communities. It was also clear that this is a great practice for learning and they are open to quality improvement opportunities. My Peacock question is: in adolescents aged 9 through 17, can parent and caregiver education regarding HPV and the HPV vaccine compared to standard care increase HPV vaccination uptake by 5% over 6 months? I chose adolescents aged 9 to 17 partially for the simple fact that you have to have consent to give a vaccine in that age, and I would have to be talking to the parents or the caregivers, and that is who I wanted to provide education to. Ages 9 to about 12 to 14 is the preferred age to start receiving the HPV vaccine, so therefore it would require parental consent, so that's why I chose that age. The problem being addressed is decreased vaccination uptake, especially in rural communities, because the CDC reported that the HPV vaccine uptake has not increased for the past 9 years in rural communities. In 2022, only 38.6% of children aged 9 to 17 were vaccinated against HPV. And the CDC reports that those living in rural communities were less likely to receive recommendation from a provider to get the HPV vaccine compared to urban communities. My proposed intervention is parental and caregiver education. My interviewee, my preceptor, confirmed for me that despite the vaccine being out for 20 years, that the same misconceptions have applied the whole time that the vaccine has been out. The decision to get vaccinated at a young age is ultimately left to the parents to decide, so they should be the ones to receive proper education to make an informed decision regarding this vaccine. My suggestion is also to discuss the vaccine at both well-child visits but also follow-up appointments. One barrier is not having enough well-child visits once they've grown, and another is lack of access, especially for small West Virginia communities. This follow-up appointment may be the only time that they're in proximity to an available vaccine. It could be the only time that they have the opportunity to receive education regarding vaccines and actually talk to a provider face to face. So I think taking this opportunity to talk about HPV and the vaccine is a great idea. The discussion and brochure could include misconceptions, evidence, statistics, and cancer risk. And I think that the discussion opens an opportunity to allow for questions so that the parents have the time to ask questions based off of the information that's been provided to them. So, current practice varies by clinic site. The clinic site that I'm referring to typically only discusses HPV and vaccinations at well-child visits. They see a lot of acute care visits and follow-up visits, and that's not typically when HPV and vaccinations get mentioned. During the well-child visit, the provider will typically reference to an online database, and if the database does not mention HPV, but the patient or the parent is kind of unsure if they've had it, I have found that care often gets delayed while trying to locate the record. And I have also found that there's a lot of parental and caregiver custody battles that are occurring, like divorce rates and children being raised by grandparents just continues to grow and increase in our area. And I have found that when the care gets shifted from a parent to a grandparent, we had a lot of children that vaccines just got dropped because things were going on in life. They are living with someone completely new, or if they were a foster kid and they were moved around. I found that if that vaccine was not in the database and not in the record, it kind of just got lost, and a lot of work had to go into figuring out sometimes, has this child had all of the vaccines that they should. My proposed practice is to address the most common misconceptions directly and provide education to the caregivers. HPV should be discussed at well-child appointments, and I think they should be discussed at follow-up appointments, just in case that is one of the only times you'll see that child that year. Although the purpose of a follow-up is not to discuss prevention, I think that providers should try to talk about health promotion at any chance that they can take. My outcome goal is to increase HPV vaccination by 5%, which will ultimately decrease cancers and genital warts. When discussing my interview, one misconception is that the vaccine does not provide automatic result and benefit, but it's important for parents to realize that this vaccine will prevent cancer later on in life. The CDC reports that the vaccine has been proven to last for more than 10 years without becoming any less effective. The CDC also reports that genital warts, precancers, and HPV infections have decreased since the vaccine's initial publication. The timeline I chose was 6 months. I chose this to ensure that the site had enough visits and opportunities to discuss HPV. And I also chose this because I wanted to make sure that there was enough patients that were being seen between that specific age of 9 to 17. Pediatrics can be a really large window from newborn to 17. So I wanted to make sure that we had enough children being seen ages 9 to 17, just in case there was a large period of time in which she didn't see a lot of people that age. I believe that this is an adequate amount of time to implement the education and see that 5% increase result. When performing my interview, it became evident to me what I had already suspected, and that is just that the public needs a lot more education regarding HPV and the vaccine. Despite the mountain of evidence that is out there showing that HPV decreases genital warts and cervical and pharyngeal and all kinds of cancers, there are still a lot of parents who are reluctant to give their child the vaccine, especially because it's not required by the school system. My fear, and especially when discussing this with my preceptor, is that the list of required vaccines has been shortened even more by the CDC. And my fear is that a lot of parents are going to reduce vaccination rates even further. And that's why I just think having this conversation and having this discussion regarding vaccines is incredibly important. And while gathering evidence from my PCOT, it became very clear that there are so many interventions that can increase the HPV vaccine uptake. There was evidence presented by the CDC showing that providers play a very significant role in encouraging the vaccine, and providers should work hard to provide great information and evidence so that these parents have the information and tools that they need to make a decision regarding the vaccine.